webinar. My name is Dennis Orthman. I'm the Associate Executive Director with SMI, and I'll be the host for today's webinar session. Today's session is just one of the resources produced by the SMI initiative team that worked on the topic of supply chain servicing the continuum of care. As healthcare systems shift their focus to broader population health efforts, care is being delivered from multiple locations outside of the hospital to meet the emerging needs of patients. This transition is a significant challenge for traditional acute care-centric supply chains. The SMI initiative team, which was comprised of industry thought leaders from both providers and suppliers, researched this topic and found there are currently many ways that supply chain providers are servicing the continuum of care. One great example is the services provided by Texas Health Resources in servicing their affiliate locations. Here with us today to provide an overview of the Texas Health program is Nate Mickish, the Vice President of Strategic Sourcing at Texas Health Resources. Nate is an experienced and recognized veteran of the healthcare supply chain, and he was instrumental in the strategic formation of a for-profit division under Texas Health called Texas Health Supply Chain Services. Nate, welcome to this SMIDU webinar, and I'm sure our viewers will learn much from you. You have control of the slides, Nate, and I'll turn it over to you.
Thanks, Dennis, and thank you, SMI, and for anybody that's going to watch this recording. So, as Dennis said, we formed a group called Texas Health Supply Chain Services as a means of providing additional services not only to our wholly owned and joint venture non-acute sites, but also our affiliate sites. A lot of the content that we're going over today will be focused on what we call owned lease managed facilities, so our owned assets in the non-acute market, be it clinics, ASCs, imaging centers, and so forth. So like many organizations in the U.S. especially, Texas Health has been in the process of transforming from a hospital system to a true integrated delivery network with more points of access and more coverage across multiple classes of trade and sites of care. So in 2010, I like to refer to this as just a sleepy little health system in DFW. Now that's obviously far from the truth, but at that point in time, we had 50 points of location or 50 access points across the Dallas-Fort Worth area, but it was primarily acute-based health system, so we didn't have a real big footprint in the continuum of care. In late 2011, that all changed when we purchased Medical Edge. That was a purchase of 250 physician offices and roughly 700 providers that were a part of that acquisition. And I believe at the time it was one of the largest acquisitions of a medical group in one particular transaction. So literally overnight, we went from being, a health system that was primarily acute focused with relatively limited access points outside of the acute setting to having right around 300 sites access points across DFW, and not the least of which a large medical group with which we didn't have a whole lot of experience in managing from a supply chain perspective. In 2012, 2013, and 2014, we really started to expand into other sites of care in the continuum, mainly ASCs and imaging centers. And again, the ASC market was either we built or acquired those facilities. And again, it was another area where we hadn't had a lot of experience in managing a supply chain. However, we did have a little bit more in common with the types of products that needed to be managed and some of the logistical elements of an ASC relative to the physician offices, because many of the product categories we were used to managing through our experiences in the acute settings. In 2015, we added another ASC, and then in 2016, we partnered with a management company and got into the freestanding ER business. So again, it was increasing our access points across DFW. Really with the intent of being able to manage the continuum of care, being able to manage populations of health as opposed to just managing the acute event. So in a period of about 6 years, we went from having 50 access points across in our health system to 350, and really expanding outside the four walls of the hospital. So this really created a couple challenges for us from a supply chain perspective, because we've been, as we were an acute-based IDN or system, our supply chain was also focused on the acute market. In expanding into the physician office space in particular, and definitely with the ASC space and the imaging space, we really had a different set of end users. And so our big challenge is we obviously wanted to implement those tried and true supply chain practices galvanized in the acute care setting, in the non-acute care setting. But the problem was there's a totally different group of players in the non-acute setting, different demands, limited capital and IT resources. And so we really had to evaluate what were the right tools and the right methods for supporting a very different user base. And I'll give you a quick example. So when you're looking at an ASC and a physician office, the people that are handling the supply chain function are likely wearing a number of different hats. In a clinic, for example, you may have an administrative assistant that's placing orders for office supplies and checking patients in, and probably also taking care of the supply orders. And the same would be true of some of the medical assistants. In the ASC space, we have some of our ambulatory surgery centers where the person who places the purchase orders and receives inventory and manages that inventory is still scrubbing into cases. And so when we were looking at how we were going to support all these end users and the different demands we were going to have, we really had to take into account that there were really limited resources and people dedicated to the supply chain function in the non-acute care setting, as opposed to the acute care setting where you have materials managers, techs, dedicated staff really managing this function. Aside from that, it's not like there was a whole lot of money to spend on implementing a huge ERP like a PeopleSoft or Oracle, at least at that point in time. And so we really had to think about what the budgetary constraints were of rolling out a system, as well as what the training constraints were going to be as well, because the more complicated the system and the harder it was for the end user to adopt the system, the less successful we were going to be in effectively managing the supply chain across so many sites of care. The other challenge was our what I call the data vacuum. So when we started in 2013, we really started in 2013. We really started to change our supply chain model and our support structure for the physicians group in particular. And at that point in time, it wasn't like they were moving from a different materials management system to a new materials management system, and it wasn't like they really had at least in the supply space, had a program that we were shifting from. So we really were dealing with limited information. And at that point in time, what we assumed to be true is that the primary distributor in the physician office space is going to carry about roughly 80% of the spend in supplies that go to that office, and all others would maybe make up maybe 20%. In reality, the all others, so the stuff that was going outside of our primary distributor from a supply spend perspective and a pharmaceutical spend perspective to our clinics, covered about 80% of our spend, and our primary distributor covered about 20% of our spend. And so, a lot of folks kind of balk at that stat, but what I would challenge folks with, and what we did to kind of identify this gap was, if you're not sure what coverage your primary distributor is actually covering for your physician office space and your non-acute space, a really simple exercise you could do is take your rolling 12 months worth of spend with your primary distributor and marry that number up against your financial statements. And so what we basically did is at the time we were using a distributor called PSS, which was eventually bought by McKesson, and we looked at what our total spend was relative to what our total with them in a year relative to what our total spend was on our income statement for the medical group, and it was roughly 20%. And so that told me that we really had a big problem in terms of we had a whole ocean of spend going outside of our primary distributor that we had limited visibility to and really no control over from a supply chain perspective and even from a fiscal rigor perspective. In terms of what our goal was, well, the first thing is we wanted, like I said earlier, we wanted visibility to all of our spend. And so it was really important that we take a system that could be scalable, that could be vendor agnostic, and put that into our continuum of care so that we could have visibility across the entire enterprise as to where the money was being spent, and also to make sure that we were getting our contract pricing, that every facility was adhering to product standards and those types of things. We also wanted better operations and really a less risky supply chain. So, for example, before we had a real well-defined program for our non-acute space, orders were really approved on the back end when the invoice came in. So, our practice managers and our ASC administrators were approving things after the expense had really been recognized or incurred, I should say. And so what we wanted to do is we wanted to have a system and a tool in place to make sure that we put power back into the hands of the managers and the regional directors before the spend was actually executed upon. So we wanted to make sure we had good approval processes And in addition to that, we wanted to make sure we had a good three-way match process for these non-acute space. These are all very basic things that we kind of take for granted in the acute setting, but you'd be surprised how few non-acute programs, or at least how few non-acute sites, really have this type of physical rigor around their supply chain. So that was a big part of our goal. The other thing is we wanted to have better partnerships, and so in a very basic model, you've really got three legs to this stool. So there's obviously us, Texas Health Supply Chain Services, in the sites that we cover. There's our suppliers, and there's our GPO. And at that point in time, there was sort of a loose affiliation between all three of these particular partners. So before we had implemented a system and had a little bit more rigor around our supply chain, we would access what we could through our GPO and try to drive compliance to our suppliers, but we had such limited visibility and control over our supply chain and continuum of care that they were really more loose affiliations than actually strong partnerships. So our solution to that was that we needed to make sure we had a good technology, a materials management information system that was appropriate for the continuum of care for all of our end users, and that could have a better tie-in for us with our suppliers and our GPO. And this is really important to us because we don't manufacture the products that we need to provide good patient care, obviously, and so we depend on our suppliers to do that. But we also, when we want to get better pricing, we can obviously utilize the contracts with our GPO, but many of our contracts require compliance, obviously, and so I think it makes a big difference to the supplier community when we know that we have the means to enforce the standard and to drive contract volume when we make a commitment. And I think that having a good, solid backbone in an MMIS with the team supporting it does a lot to let the suppliers know that when we make a commitment, we have the wherewithal to meet that commitment. So how did the goal become attainable? We had, like I said earlier, we had over 300 sites of care that we had to manage from a supply chain perspective. Didn't have a lot of experience as an organization in managing the supply chain in the non-acute sites. So we had a lot of work ahead of us, and really we're dealing with what I like to call just a lot of chaos in the supply chain in the non-acute sites. So we had to find a way to bring some order to what we knew was really a lot of money going to places that we didn't fully understand. So the first thing is we wanted to create a support structure around the right technology. As I said on the prior slide, we had to go a long way in finding a good tool that was going to work well in the non-acute space in terms of a materials management information system. But that's really only half the battle, and maybe not even quite half. You really have to create a support structure to implement and maintain that software, but also to make sure that at the adoption rate amongst your users stays very high. And so it was really important to us to really adopt a customer service type orientation with even our own facilities, because the fact of the matter is there are a lot more of them than there are of us. And so if you're trying to manage the supply chain effectively for a large medical group like Texas Health Physicians Group, you need to make what we call the right way the easy way. In addition to that, we wanted to continuously educate and receive feedback and continue to improve the end user experience. This became very important for us because, as I said earlier, this was the first time as an organization that THR was really proactively managing the supply chain, and we knew we had a good technology, but we always had to make sure that we were providing really good service. And then we also had to continuously train our folks because, Texas Health Physicians Group, our big medical group, is 250 offices, and it's been 250 offices over the last several years, but the composition of that group has changed dramatically over time. And so we're kind of in a state of perpetual implementation. And then maintenance. I mean, that's a key no matter where you're at in supply chain, whether you're on the acute side or the non-acute side, but it's just as important on the non-acute side that you maintain your item master well, you maintain your user profiles well, your approval rules, all those types of things. Because at the end of the day, if the software isn't user friendly, if folks aren't finding if their profiles aren't up to date, and if they aren't finding the items that they need to order in the item master, it's highly likely they're going to stop using the system. And so all these major themes kind of added up, excuse me, resulted in what I just consider sustained adoption. So, and when I say sustained adoption, I mean, implementing this system out to all of our sites of care was really a new thing about 4 years ago. But we didn't want to just implement it and claim victory and move on. We wanted to make sure that year over year, people were using the system and adopting our standards from a product perspective, our contracts, and our fiscal accountabilities. So in terms of our actual results, as I mentioned earlier, in 2013, we started implementing the MV platform, which is our MMIS, into our physician group. So you notice that our volume was, our PO dollar volume at the time was just under $4 million. We started in July and wrapped up in the implementation in November. So we didn't get a full year's worth of spend there. But the other thing to kind of notice is what our primary distributor volume was with our clinic group for that period of time, as well as our premier contract volume. 2014, we had our first full year with THPG, our physicians group, running the platform. We expanded our service to the ASCs that we had at that point in time and our imaging centers. And so our PO dollar volume went up significantly, as did our primary GPO contract volume and even our primary distributor volume. In 2015 and 2016, again, first, we saw some same-store growth with our medical group because we just had, we were expanding coverage of what was going to be on a purchase order going through that platform. So we wanted more of the purchase service type spend to go through that platform. We had growth with our ASCs and our imaging centers. And then in 2016, again, more growth with our ASCs. And so at least through 2016, we were just under $81 million total spend. I'm projecting that in 2017, our non-acute program will hit about $100 million in spend through the NV platform. And you saw that there's just a natural pull towards your premier contract volume. So our contract volume increased, not quite commensurate with our PO dollar volume, but you can see that by specifically owning the transactions across the continuum of care, we were really ensuring that our contract volume was being maximized as well. But
hello, Nate. Nate.
Yeah.
I'm sorry, Nate. This is Dennis. I'm blown away by these numbers. $80 million, and you're predicting over 100 for 2017. Are those numbers surprising to you?
Not exactly. Not with the kind of growth that we've had. But yeah, I think that for us, and this kind of comes into what I'm going to talk about in a minute. I mean, I think it would have been more surprising to me a few years ago because, it depends on the organization. Some organizations just kind of see their non-acute market as a rounding error, so it's really not worth troubling with. But again, that's why I say if you're considering putting together a supply chain program for your non-acute sites, you really should start with just looking at the income statement so you understand how much money is actually out there.
Yes, there's a lot.
Yeah, go ahead. Sorry.
No, we're just finding out within the SMI team that there is a lot more volume out there than people generally perceive.
That's exactly right. Well, and the other thing that's kind of surprising to folks too is just this gap between what's going through your primary distributor, which is that blue bar, and then the green bar is the PO dollar volume. And so what I said earlier really has been our experience that only roughly 20% of our total supply spend goes through our primary distributor, which means that if you're relying on your primary distributor to be your non-acute program, you're seeing a pretty small piece of the picture. The other thing that a lot of folks find surprising is just the what I call kind of the GPO penetration rate, especially in the non-acute side. Most acute providers, when you really look at your GPO coverage as a percentage of your total spend, is probably closer to 70 or 80%. In the non-acute market, it's really around 40 or 50% if you're lucky. And a big part of that, I think, is that GPOs can only be as effective as their members are in collecting data. And there's a lot of spend in the non-acute space that just simply isn't covered because GPOs don't even know that that's a contract category worth pursuing. So, Dennis, do you find those numbers surprising at all?
They are consistent with what we've been hearing from others. So,
okay.
The low distributor penetration in the improved, but still not as robust as people think GPO penetration.
Mm-hmm.
That's great stuff. Thanks, Nate.
Yeah. So at this point, you might be thinking to yourself, well, it's really great. You've got this wonderful adoption rate over time, Nate, but what's it actually meant for your organization in terms of saving real money? So one of the metrics that's really important to our medical group is cost per work RVU. And if you don't know what a work RVU is, you've probably heard of an RVU, which is a relative value unit. A work RVU is a way of really measuring productivity and acuity level of a physician's time. And in fact, many organizations are working to a work RVU driven comp model for their doctors, compensation model for their doctors. And so what we've done as an organization to measure our improvements in operations is to look at our cost of our medical group as the supply cost as part of the work RVU. And so in 2014, when we started measuring cost per work RVU for supply expense, it was around $6.20 per work RVU. In 2016, we reduced that to $4.79. So it doesn't seem like a real big shift. I mean, it's as a percentage, it's pretty big shift. But when you spread that over, millions of work RVUs, that 23% reduction resulted in a $6 million improvement in our operating margin. And a big part of that came from, making sure we had our contract pricing loaded, getting a good deal with our distributor. But the bigger driver for us in terms of savings was implementing a PO approval process and allowing the managers of these businesses and of these clinics to have the control to deny orders before they go to suppliers, which doesn't make everybody happy, but it does help us in terms of having better cost containment and making sure we're buying the stuff that we really need to be buying. So for us, that was our organization obviously really appreciated our efforts around this, but it was the behavioral change, I think, that made the biggest difference in driving down costs for our medical group.
Wow.
I'm just going to kind of wrap this up real quick. Just to leave you all with some actionable tips and some things that we kind of learned along the way in this process. So the first thing I'd say, and I'm just going to be real honest and frank about it, is don't kid yourself. If the extent of your non-acute program is a distribution relationship, then you don't really have a non-acute program. So you really need to decide whether or not your non-acute supply chain is a priority. And that last sentence is really the most important part, because if your organization doesn't see it as a priority and they're not going to put some resources behind, proactively managing your supply chain, then you're really going to have a hard time making a lot of progress in that space. And it's not just about getting technology; it's also about getting the right people and the right support model to implement a technology and to take care of your end users in the non-acute sites. The second tip is, if it is a priority, then start evaluating an MMIS that is appropriate for your organization. Some organizations might have the support model and the cost structure to implement what I'd call a kind of a big box ERP, like a Lawson or an Oracle or an SAP, something along those lines. But if that's not the case, or if you don't have the funds to do that, there are a number of what I call best in breed type of materials management systems that are web-based, that aren't quite as expensive, and they are really user-friendly. Because again, it's getting the right tool in their hands and the right support model behind it into your non-acute sites. Because the last thing you want to do is pick the wrong technology and then nobody uses it and you're just kind of spinning your wheels.
Mm-hmm.
So the third point is, remember that ongoing support is what will ensure success. So you need to build or buy a team. And I say build or buy because there are a number of programs out there that you can work with a support provider like Texas Health Support Service, or Texas Health Supply Chain Services, and other organizations that that can become a little more transactional in terms of the support of the software and the implementation of the software. But either way, I just want to make sure everybody understands that if the technology itself is not the silver bullet, you're really going to need to invest time and resources into people to make sure that you're maintaining the system and that you're providing good customer support and ongoing education. And then finally, don't allow perfect to be the enemy of good. You need to get started. And so, when we go back to 2013 and 2011, we bought the medical group, and then in 2013, we really started implementing a software and trying to get a little bit more control over our supply chain. It seemed like a pretty daunting task because we didn't have a lot of data. We had 250 physician offices. We didn't have a particularly large team at that point in time to support such a large group. But we really just knew that we had to put a good plan together and execute upon that plan. And if it means rolling out in a staggered fashion with a less than complete item master, then so be it. Because over time, if you got people using the system, using an MMIS, issuing purchase orders through that system, you're going to get the data you need to complete your item master. And so you just don't want to wait until you have all the information before you implement, because you're never going to have all the information. And so with that, if there's any questions, Dennis, or discussions.
Nate, this has been fantastic. I want to, first of all, congratulate you on the great success that your program has had. as evidenced by the statistics and also as evidenced by the energy that you put into this. Thanks so much for doing this. Let me point out to our viewers that there are additional resources on the SMI website related to the continuum of care. The SMI website is smisupplychain.com. We're happy to provide this webinar. And again, Nate, thank you so much. Very, very educational, very worthwhile for our listeners. So again, thanks, Nate.
Thank you, Dennis. I really appreciate the opportunity.